Hello, everyone. Thank you for joining. I'm going to share my screen. All right, there we go. Everyone see that? Perfect. Thank you all so much for joining our session today. We are so excited to have you all here. We are going to start with a quick presentation to share a little bit more about pre-health shadowing for those that are new, and then we will toss it over to Dr. Becker. We are Pre-Health Shadowing. We are an international student-led nonprofit for medical advancement, meaning that we are really passionate about sharing information about the healthcare field with folks who are interested, no matter their area, location, ability, or age. So thank you all so much for joining us today. We're really excited to have you all. Just as a PSA, we do have closed captions available to accommodate all students. We are very interested in making sure that PHS is accessible to everyone. So if you ever have any ideas for us, please send us an email at info@prehealthshadowing.com. Just in general, that's a great email to have to reach us. Please save us as a contact, keep us out of your spam, and join our email list because we do email every single session that we have. And we'd love for you all to keep joining us. If you want to stay in the loop, we have options. We have Instagram, TikTok, X, YouTube, Facebook. Also, special shout out to LinkedIn if you're looking to expand your professional network. That's a great way to do it. Please follow us on all of our social media. We stay very active and we also upload all of our sessions onto YouTube. So if you want to watch it again or have any questions and want to reach out to our team after the fact, please go through those socials. We are very excited to be an international student organization, so we would love to know where you all are calling from. I'm calling from Maryland today, and I'd love it if you could all drop in the chat where you're from. I see one of our volunteers is from North Carolina, Connecticut. Shout out to Southern California, that's where I'm originally from. Texas, Virginia, NYC, Maryland, Oregon, Tempe, Arizona, Georgia. That's so cool. Thank you all so much for being here with us today. We know that time zones are different everywhere, so wherever time zone you're in, we are so excited that you're making the time to join us. If you're interested in becoming a part of pre-health shadowing, we do have a variety of opportunities for you to get involved. You can be 100% remote with all of our volunteer opportunities, so please register as a volunteer on our website. We have a list of our available opportunities for you all there. If you have a little bit more time on your hands, about 5 hours a week, you can apply to join our leadership team, also 100% remote. This would just require a little bit more of a time commitment. We have a full list of available roles on our website in grants, fundraising. If you're interested in live sessions like we all are, please feel free to message any one of our team members, and you can use the link that's in the chat right now to explore the leadership roles with PHS. And if you're interested in developing any new leadership roles, we're super open to that. We're really creative in terms of our process and making PHS more accessible. So let us know if you have any new innovative ideas. If you are a high school student, you can join our high school training program, which would be an opportunity for you to bring healthcare education to your high school. So that looks like you connecting with pre-college organizations as well as fundraising efforts for PHS and live sessions just like this. So please join our Instagram at prehealthshadowing.htp and also fill out our interest form that's on the healthcare training program website. If you can, we would humbly ask that you donate anything that you have to PHS. We do run 100% off the donations of our supporters, and we're so incredibly grateful for folks that can donate $1, $2, anything you have. Please do so to help our program stay free and accessible to everyone. Another way that you could donate would be your time, like the previous leadership opportunities that I suggested. We are so grateful for anybody who gives PHS some of their time and money and any energy that you have to help keep us accessible for all of our students. Throughout the presentation, we would love it if you could all type your questions in the chat. We are making note of them and we will have a dedicated Q&A at the end of sessions to ask Dr. Becker. But if you have anything that you just don't want to forget, please store it in the chat and we'll make sure that we're going through them and getting all of our questions answered. Additionally, it'd be great if you took good notes because we do have our post-shadowing assessment available to earn immediately after the session ends. We'll have an extra information about that at the end, so don't worry at all, but make sure that you're taking good notes. There's a lot of fun vocab, a lot of new things that you may hear, so we're excited for you all to be able to engage in that way. And lastly, if you could turn your cameras on, we would definitely appreciate it. We understand that everyone's in a different situation, so no pressure at all, but it is super fun to see your faces. We do spirit fingers, jazz hands, whatever you call it from time to time. So please engage with us with your video on if you can. And with that, I would like to toss it over to Dr. Becker. We are extremely grateful to have you here today and can't wait for you to share with our team.
Great. Hi, everybody. I will say good afternoon to some of you on the West Coast and good evening to those of you on the East Coast. It's 8:30 my time, so I appreciate you all being here. I'm just going to share my screen. Okay, let's see if this works. All right, can everyone see this?
Yes.
Yes.
Okay, great.
Yes.
All right, so I'm just going to start here. So I'm Jacqueline Becker. I'm a clinical neuropsychologist. I work at the Icahn School of Medicine at Mount Sinai here in New York. And I'm actually in an unusual position for a neuropsychologist in that I'm housed in the Department of Medicine in the Division of General Internal Medicine. So most of my colleagues are actually MDs, and I'm actually one of the only PhDs in the entire department, which is interesting. Certainly the only one in my division. But I wanted to tell you a little bit about sort of my trajectory and how I got here, a little bit about neuropsychology more broadly and what it entails. And give you a little bit of a sense of my day to day and hopefully answer any questions that you all might have. So to start, what is a neuropsychologist? So I like to think of myself as sort of being the translator. So I take things that we can't really see, right? So things like attention, memory, how quickly we think about things, language, and I essentially turn them into something that we can measure, right? So a lot of times a patient will come in and say, I don't feel as sharp as I used to, or I used to be able to multitask and now I can't. Or, this is what my day to day used to look like and now it doesn't look like that anymore. And I don't really understand why. And so by talking to a patient and by doing a series of tests, I can help them understand what might be going on and why. And so the textbook version of what a neuropsychologist does is we study brain behavior relationships. This is sort of a buzz term, but this is one that we talk about a lot in my field. So, what that means is just how an injury, an illness, or a disease can change the way that people think, feel, and function in daily life. So, one question I get asked a lot is, well, why not just, put somebody through an MRI if they're struggling, right? Or why not do some sort of neuroimaging? And the reason is because neuroimaging tells you something entirely different. It tells you about the brain's structure and not how it functions, right? So a lot of times we'll have somebody, who is really struggling day to day and their MRIs are entirely normal. Sometimes we might find something incidental on an MRI, like a brain tumor or like a cyst or some other structure. And conversely, the patient is doing totally fine day to day and has no difficulties at all. And so just seeing an image of the brain doesn't give us as much information as one would hope. So, what a neuropsychologist does is we turn that information into something actually measurable, and that translates to what somebody is experiencing in their daily life. Any questions so far? Okay, I'm happy to make this more interactive if that's helpful. So, neuropsychologists are essentially in charge of assessing. So, that's one of the biggest things that a neuropsychologist does. So, we do evaluations, we measure thinking and cognition using standardized tests. And these are very precise tests. They're not just, it's not based on clinical judgment. These are considered objective tests. Oh, I see a hand up. Edwina?
So I had a question. So you said you have a PhD. So does that mean that instead of being physically being hands-on with the patient, are you more behind the scenes, if that makes sense?
No, we are hands-on with patients. So we meet face to face with a patient, and I'll actually go through what, an evaluation might look like in just a minute. But we are patient facing for the most part, unless, there are many neuropsychologists that do only research and see no patients. Um, but yes, does that answer your question?
Yes, thank you.
Yeah. So yeah, so our role essentially is when we do these evaluations, we use these standardized tests. And by standardized, it just means that everybody takes the same tests, right? And so what we do to make those tests fair is we use something called normative data, which means we compare somebody's test scores in two different ways. One is we compare them to the population norms, which is someone of their same age, education, and sex, for example. And the second way that we compare those scores is to themselves and how we expect them to be doing based on what their sort of baseline IQ is. And we do that through, again, a series of tests. And through those evaluations, when we meet with a patient, so we'll meet one-on-one with a patient, we do a full intake, which is usually like an hour to an hour and a half interview, again, face to face with a patient, sometimes also with their spouse or their caregiver, or in the case of pediatric neuropsychologists, their parents. We ask a whole series of questions, get a very comprehensive history. It's sort of our opportunity to play detective. Then we have them do a series of tests. And once they leave, we score everything and we write up a comprehensive report. And from that report and from those test scores, we are able to come up with a diagnosis. So we can sort of disentangle many aspects of cognitive change. So we can say cognitive change might be due to a specific disease, due to a specific injury. Maybe it's due to poor sleep. Maybe it's due to low mood. Maybe it's due to a medication side effect. So the reason we do that detective work that's here in the green is so that we can get to that purple and actually formulate a diagnosis. Then we sort of guide treatment. So cog rehab, cognitive rehabilitation is sort of a treatment that teaches compensatory strategies and can help it's based on the theory of neuroplasticity. So neurons that fire together wire together. Essentially, what that means is the more that patients practice doing something, the more they strengthen those neural networks, which means, you know, the more that, say that you're having trouble multitasking, well, the more you practice multitasking in this setting, the better you can strengthen those networks. Um, One note about cognitive rehabilitation is that the research is actually a little bit mixed on that for which populations it works well for. So, for example, it works really well for stroke. So, when someone has sustained some sort of injury and now they're having trouble speaking or multitasking or doing some other cognitive task, it doesn't work so well, though, in the case of normal aging, where, for example, memory might start to deteriorate or decline over time. Cognitive rehabilitation has not been shown to reverse that, if that makes sense. But that's one of the things that, makes our reports useful is we can sort of guide people toward, which treatments may work and which may not. We can also guide them toward accommodations. So, for example, for kids or adolescents or college age folks who are going to school, this might be extended time on tests. This might be, specific accommodations to help them do well at school. People at work, we also do accommodations like, reduced work weeks or working from home and things like that. So we essentially create like a roadmap for patients to use. And then the other part that clinical neuropsychologists also do, and that I do especially, is research. So I'm actually faculty on the investigator track, which means that 100% of my time right now is dedicated to research. So what's cool about that is it helps, it gives me sort of time to answer a lot of really critical questions in the field, a lot of, sort of tackle a lot of gaps that haven't been explored. And also, because I see patients through a research-funded clinic that we have, those patients inform the research that I do, and that research sort of goes back to them. So it sort of is a full circle moment where, my research directly informs my patient care, and my patient care directly informs my research. Um, so where neuropsychologists typically work, we're typically in academic medical centers, hospitals, rehab settings. The VA has a lot of neuropsychologists. There are a lot of forensic neuropsychologists who do work on with the courts or with disability evaluations. A lot of them who work in private practice, and a lot of them who work in research institutes. And again, I'm simplifying. Neuropsychologists are also really good at doing a lot of different consulting. So we can consult for pharmaceutical companies, neurotech or biotech companies. A lot of, pharmaceutical companies who are developing a new drug, for example, might retain neuropsychologists as sort of consultants so that, to help them understand the clinical meaningfulness of these drugs and what they can and can't do for patients clinically. So again, you know, something different than we would see on a scan or a blood test. And one example of that would be like in Alzheimer's disease, if you've heard, a lot in the news and in the media about some of these drugs that are being developed to potentially treat Alzheimer's disease, you know, they're they may do blood biomarkers and look at proteins like phosphorylated tau in the brain or beta amyloid and things like that. But it doesn't mean anything if the patient is not experiencing symptoms. And so the way that we know if they're experiencing symptoms is through neuropsychology. That's sort of our role. So these pharmaceutical companies really develop on really rely on neuropsychologists to sort of explain what sort of clinical symptoms patients are experiencing and whether these drugs are actually improving upon those or not. Edwina, I see your hand up.
I believe someone in the chat is asking a question. I'm not sure.
Yeah, I think we'll save some for the dedicated Q&A at the end in the chat, but feel free anyone to raise your question if you have
Yeah, I'm
it.
not monitoring the chat. Sorry.
Yeah, no, we got it.
Okay. Just to clarify one thing that is a common misconception. Um, Talking about the domains in particular that we measure. So cognition is not one thing, right? So we like to simplify it and say it's our thinking ability, but we don't measure one thing called intelligence or just cognition in general. The brain is not, it's one organ, but we actually separate cognitive domains and look at patterns to see what's strongest and what's weakest, and that helps inform the diagnosis. So even if someone comes in saying, I have memory problems, we don't just test memory and say, you're okay or yes, you are having memory problems. We look at all of the different domains because none of these work in isolation. The brain is a network. And so all of these sort of work together. So an example is, in order to have memory, you need to have attention, right? So you need to pay attention to information in order for, your brain to take it in, hold on to it, and then you need to be able to recall it later. You also need to have language, for example, right? Where if the information is presented verbally, if you get a verbal word list, then you need to have language in order to have memory, in order to remember that word list. Or, you need to have visual spatial abilities in order to have memory if it's visual information that you're trying to remember. You also need to have something called executive functioning, which I like to think of as being like the CEO of the brain, which helps us organize, plan, have self-control, control our emotions, be cognitively flexible, right? And so if I gave you like an unstructured word list, for example, you need executive functioning to help yourself organize that information to make it easier to remember later. So these are just examples of sort of how all of these domains work together. And oftentimes, even though we may perceive, for example, memory difficulties, sometimes the problem is with attention and that the attention wasn't there to begin with. And so there was nothing to recall later. And so, the key idea is that, you know, it may be any one of these things, but it may be a combination of domains that is impacting someone's day-to-day functioning. And so the way that the pattern comes up on our tests is what really matters and what points to an underlying cause. So now let me shift now to just talk you through a little bit of what my path was like through school for those of you interested. Oops. Oh, how do I go back? Okay, there we go. Um, so first I completed my undergraduate degree. So I majored in psychology at the University of Miami. I actually minored in sociology. Um, One thing that's missing here and I didn't include it here because it's sort of optional. But I did also, after my undergraduate, get a master's degree in mental health counseling, and that was a 2-year master's degree. At which point I started to see patients clinically. So I was a therapist. I worked in various different settings, so mostly in substance abuse. I did some couples therapy and marriage and family therapy, and things like that. And after being a therapist, I realized that there was so much more to psychology that I still felt like I needed to learn. So I started working in research, and I worked at Columbia University for a few years, for 3 years actually, before starting to apply for my doctorate. So, again, undergraduate, master's degree, worked for 3 years, then PhD. So, normally a PhD is about 5 to 7 years. I completed mine actually in 5 years because I was able to defend my dissertation before my internship year. So basically, I studied clinical psychology. The PhD is in clinical psychology, and I did it through the health and neuropsychology track at Fordham University. And health and neuropsychology is what it was called at the time. Now, actually, they have two different tracks. Now they have a health track and a neuropsychology track. But at the time when I went in, it was sort of subsumed under both. And interestingly, I went into my doctorate wanting to do health psychology, and I wasn't interested in neuropsychology at all. And so I was working at Memorial Sloan Kettering Cancer Center through the first 3 years of my doctorate as a research assistant. Just working with different stages of cancer and different kinds of cancer patients until I started realizing how much cancer and its treatments were really impacting cognition and impacting the brain and impacting people's ability to complete their chemotherapy. So a lot of these people a lot of the patients I was working with at the time, were finding that they were having so many cognitive deficits from their cancer or from their chemotherapy that they weren't able to continue with those curative treatments. And so I became really interested in the brain and how, susceptible it is to not just, something like chemotherapy and these drugs, but also, cancer itself, even if the cancer wasn't primarily in the brain at all. And so that kind of led me to do a few different clinical rotations in neuropsychology. So at that time, I worked at Cornell for 1 year in neurosurgery. And so what I was doing there was basically helping with awake craniotomies, which I'm happy to talk about a little bit later, and seeing patients before and after brain surgery. I also then worked at Cornell in the inpatient rehabilitation unit. So these were people, a few weeks after their surgery that needed cognitive testing, to sort of see where they're at and help inform their rehabilitation. So do they need speech therapy? Do they need more motor, dexterity? Do they need more cog rehab to work on memory or language functioning and so on and so forth. And so, I found this super interesting, not just how fragile the brain is, but then also how resilient it is and how well it recovers. And then from there, I started working in a more general epilepsy center. So started seeing people with various neurologic conditions, with a lot of dementia patients as well. And this really helped sort of round out my training where I was starting to understand, structure and function, and sort of how the brain worked and what it meant throughout the degree and throughout the course of somebody's injury. And then so I did my doctoral internship at Harvard Medical School, Mass General Hospital, and this is a 1 year requirement in order to finish the PhD. So, the last year of the PhD essentially spent in the internship year. And this is sort of the equivalent of our like residency. So it's a match program. You apply to many different places and you interview at a bunch of different places, and then you rank them, and ultimately you get, just an algorithm telling you where you're going, essentially. So I matched in Boston and I spent my doctoral internship there. And then in order to become a neuropsychologist, you also need to have 2 years of specialized fellowship training. So that's where I did my postdoctoral fellowship at Northwell Health in Long Island. And that's sort of what allows me to call myself a neuropsychologist. So after the internship year, I finished my PhD, but I was just a clinical psychologist. So that those 2 years is what allows me to call myself a neuropsychologist. And then after fellowship, you have to get licensed. So that just is basically like a state exam that you have to take. And that's the year that I became faculty. I transitioned to a full-time research role at Mount Sinai. And so, in general, I would say that after undergraduate, people can generally expect it to take about 8 to 10 years from the start of a PhD to, finishing postdoctoral training. However, it can sometimes take longer than that. And certainly if you start with a master's degree. You don't have to start with a master's degree, but because PhD programs are so competitive, it often helps a lot to have had some sort of related master's degree before. And just to give you some context, Fordham's, I sometimes help with Fordham's admissions process. And this year for our PhD class, we had over 2,000 applicants for which we only accept 7 people. So just to give you some concept in terms of, how challenging it can be to get into a doctoral program. However, one caveat to that is that PhD years are usually funded. So while med school students are often racking up a lot of debt, not saying that I didn't rack up a lot of debt, but the nice thing about being in a PhD program is that your entire tuition is completely paid, and you get a stipend. So you're essentially getting paid. It's a small stipend, but you're essentially paid to go to school, and that's your job, right? That's your salary. And this is in exchange for, work that you're also doing as part of your mentor, whoever your designated mentor is. They usually have a lab, they usually have research funding, and that's how they're able to support your salary and your tuition. But that's essentially the road to being a neuropsychologist. Yes, I see a hand up.
So I'm not completely sure if I got this right, but um, to be a physician, is it like fine to like just choose between MD and PhD, or is there like a specified path?
So to be a physician, that would be an MD. To be a clinician, you can have an MD or a PhD or both. So to be an MD, you have to go to medical school. Um, to be a PhD, you have to get a doctorate in a specified PhD program. There are also some people, once they're in medical school, that will go through an MD PhD track. So a PhD is the highest academic degree one can get, right? It's 5 to 7 years of academic education. An MD is the highest clinical degree that somebody can get. So what that means is basically medical school is 4 years. If you want to do an MD PhD, that means that you want to not just be a physician, but you also want some level of research. So a little bit of that academic portion. So academic implies research. So usually PhDs are 50-50 research clinical. MDs are usually 90% clinical, and you can mix in a little bit of research. MD PhDs, you can do sort of 50-50 clinical and research as well, but you're more on the ND track. So you still have to go through all of the requirements of medical school, which is very different and not as specialized as something like a PhD, which you're very specifically, so if you're doing a PhD in biology or psychology, like that is the focus of your study. Whereas medical school, you do many different rotations and choose your focus sort of toward the end. Does that answer the question?
Yes. So,
Okay.
so what's like the exact difference between a clinician and a physician?
A physician is an MD, and a clinician doesn't have to be an MD. It can be a PhD. So I can't call myself a physician because I don't have a medical degree. So I'm not a physician, I'm a clinician. So I do clinical work. But
Okay.
does that make sense?
Yes, that makes sense.
Okay.
Thank you.
Yeah. All right. So, oh, Edwina?
Yes, I have a question about like the workplace. So do you work with the doctors and also like nurses and physician assistants and nurse practitioners, etc.?
I do, yeah. But I work in an academic medical center and I work a lot with neurologically ill or chronically ill patients. So that's the patient population that I work with. A lot of neuropsychologists will work with dementia patients. So they are sort of isolated in, a different clinic, like an outside clinic or a private practice, and they do evaluations with the patients that are referred from doctors. So they may never see the doctor or speak to the doctor, but doctors will place a referral and say, here to the patient, go get a neuropsych evaluation. The neuropsychologist will write up a report and send it to the doctor. And that's the extent of that collaboration. So that's a very common thing for a neuropsychologist. For me specifically, I work in primary care. So I work directly with primary care doctors, with nurses, research nurses, with surgeons, with, PAs, physician assistants. So that's sort of my role, but that's not what every neuropsychologist does. Does that make sense?
Yes, thank you.
Okay. So in terms of what I did outside of class, so I told you a little bit about the education that I got. But I think the single highest value thing that you can do, if you are interested in a PhD would be research experience. And I really can't stress that enough. It's not just, research experience like you're just volunteering in a lab, but you're co-authoring papers or doing posters and things like that. So demonstrating a research interest is critical for a PhD. Again, for MD, that's not so critical. It's helpful certainly, but it's not critical. For a PhD, if you have zero research experience, you will have a very difficult, uh, I might even say impossible time getting into a PhD program. And the way that I did it is I emailed professors until one said, yes, I'm interested. And so, it's all about the relationships and networks that you build with researchers. Watching real clinicians work also helps, to know what it actually feels like. So I shadowed neuropsychologists, again, like sometimes reaching out or working your network or, talking to an old professor and seeing if they know someone that I can work with. That kind of thing is also really helpful. Doing any kind of internship, paid work counts, of course. But internships are also really important. So, as much as it's hard to just volunteer your time for free, it goes a long way, at least in developing connections and things like that. And then, being involved in clubs and other organizations is really important. So, for example, when I became interested in neuropsychology, I joined the International Neuropsychological Association, and the American Psychological Association, the American Psychiatric Association. I looked at all of these different organizations and just started attending lectures where I could so that I could network and meet people. I went to conferences, I submitted posters. So that kind of thing, and all of these organizations are always looking for student members that can help, help run a meeting, write meeting notes, things like that, that are often very basic, but that gives you a leadership role that you can add to your CV, and that often looks really, really good for these programs. So just a little bit about the patient populations that I worked with. So, as I was mentioning, I started working in neurology and neurosurgery. So, I worked a lot with people with epilepsy or brain tumors who, had to have a neurosurgical procedure to either take out a tumor or take out a piece of the brain. And so for that, a neuropsychologist role is testing while the patient is having surgery, which I know seems a little bit crazy, but it's called an awake craniotomy. And so the patient is twilighted, so they can't feel anything, but they're essentially woken up in the middle of brain surgery. And we help guide the surgeon, in order to preserve as much eloquent cortex as possible. So, for example, one of these procedures that I did a few weeks ago was for language mapping. So a patient had a brain tumor in an area that could impact his language functioning. And so, as the surgeon was going in and cutting, I had to engage the patient in conversation. I had to do some testing with him while the patient is removing this tumor, or while the surgeon is removing the tumor, rather. So, that's an example of sort of where my training started and where, it's a part of what I really have liked to continue in the work that I do now. In clinical work, I also did a lot of Parkinson's, Alzheimer's evaluations, traumatic brain injuries, chronic traumatic encephalopathy, which you may know of in the media a lot, which is something that happens to football players. So I, worked for the New York Jets and the New York Islanders for some time, doing pre and post-season testing where we were, making sure that essentially we establish a baseline before the football season starts so that once they start getting concussions, we can sort of map, how their cognition has changed, if it has at all, and sort of make return to play evaluations and things like that. So these are, these were all very interesting sort of areas to work in, and I definitely did a lot of different things in my training, which was cool, and it sort of helped me narrow my focus. And then again, from all of those conditions, I started studying cognition and chronic illness. So again, seeing the effects that a lot of these illnesses had on the brain. I then started working in research and started studying cognition in conditions like asthma, in COPD, in breast cancer, in patients with diabetes, in patients with liver transplants. And this was about in 2019 when I was just sort of getting started with this research. And then came the pandemic. And so, pretty early on in the pandemic, in about April of 2020, Mount Sinai started putting together the Mount Sinai post-COVID registry. And we figured, well, there were a lot of, older adults being impacted by COVID-19. Let's start giving cognitive testing to, people post-COVID to see and track over time whether they sustain any cognitive deficits. And from that, we became actually one of the first groups in the world to talk about the post-infectious condition called long COVID, which is, when people get a lot of different symptoms that don't resolve after having a SARS-CoV-2 infection. And so from that, we started studying post-viral illnesses in general and saw that it's actually way more common than we previously thought, where people would get these viruses and a lot of them would never get better. So some of those conditions are chronic fatigue syndrome, what's now called myalgic encephalomyelitis. And so, was a lot of stigma and still is a lot of stigma associated with these conditions. And so what was interesting is that our tests actually showed that these people were really cognitively impaired, whereas all of their other symptoms were pretty subjective, like pain and fatigue, and very hard to measure. And so a lot of people thought, well, it's probably just anxiety, or it's probably just, they're not sleeping well. And we were actually able to measure, like, no, this is real, this is really happening, and these viruses are really impacting the brain in very real and measurable ways. So that's a little bit of where my research went from there. So, again, just to talk a little bit about some of the cases that, that have stayed with me. The awake brain surgery that I mentioned, those are always, one where especially when it goes right, that you just feel like you're really making an impact in someone's life, right? So like being able to preserve someone's language functioning where they can remove this tumor that is growing in their brain and they're still able to do all of the same things they used to be able to do. And that's because of your help, right? So that really always feels really good. The brain fog, long COVID brain fog is another part where we mostly see people who are really high functioning. And so, they tell us like, I was a surgeon or I was a lawyer or I was an investment banker. And now, I can't work anymore or I can't care for my kids in the same way because, I just can't remember to pick them up or whatever it is. And everyone else has been telling them, it's all in your head, you're anxious or not believing them. And here we're able to actually see it. And so, it's been a really rewarding, I would say, and really timely area where, we've been able to sort of help these patients in very meaningful ways. And then, I mentioned a little bit the forensic neuropsychology and disability cases. Sometimes I'll do those as like part of my consulting. And so what that means is, someone might, be applying for Social Security disability or something like that, and their case gets denied a bunch of times. And so their attorneys might hire me to do an evaluation myself or to look through other evaluations that have already been done for that patient so that I can write a formal report about disability to help that patient. So those are just some really important parts of the work that I do. I think in the interest of time, we'll just skip through cases and get to Q&A because I see the questions in the chat increasing as I go. So just a typical day, I would say no 2 days are the same. I might test a patient in the morning, be scoring the report midday. In the afternoon, I'm doing research and different kinds of grants, writing different kinds of grants, and then across the week, I might be doing team meetings. I might be teaching the medical residents. So a lot of different things I would say that happens in my day to day. An example is, last week on Monday, I was scrubbing in the OR at 6:30 in the morning to help with an awake craniotomy. I was out of the OR by 1 o'clock and I just had Zoom meetings all day. And then I had to work until like 1 o'clock in the morning because I had a grant deadline that was due on Wednesday. So like doing research, doing clinical work, and then the next day I'm seeing patients in clinic in the morning. I'm, working with my team and supervising postdocs to see their patients. So it's a lot of different things that I do all at once, and it's exactly why I've really loved the job, right? I have a lot of flexibility. I make my own schedule. I'm able to work remotely on research days, and I go in to see patients on other days. And so, being all these, having all these different roles, really gives the work a lot of meaning and you know, gives me a good balance, I'd say. Oh, a hand up. Hi, Shreya.
Hi. Yeah, so I also asked this in the chat, but all of the experiences you're talking about are just so cool and so interesting. So I was wondering if, getting this diverse amount of experiences that you have and that you do perform in your day-to-day life, would that be something that um like every clinical neuropsychologist like could potentially, a day in the life could look like for them, or does it
Totally.
vary based?
Yeah, so that's a great question. A lot of neuropsychologists prefer to do one thing, right? So a lot of them, for example, will work in an epilepsy clinic. So every patient that walks through their door has epilepsy, or it's either pre-surgical case or post-surgical case, and that's all they do is they only see epilepsy. Some neuropsychologists are rehab neuropsychologists, and they only work in rehab settings. So post-stroke, post-traumatic brain injury, right? Some are forensic. They only do disability evaluations. So in an academic medical center setting, and if you have an interest in research, you can absolutely make it work where you're doing research and submitting grants and that's something that you enjoy and you can also have some clinical time. I would say that it's a lot easier to do more research and then have clinical time than the other way around. Once you've been doing clinical work for a really long time, getting into research can be really challenging. But it's still possible. And a lot of people do it where they, do clinical work for many, many years and then they transition to a research role. Or, they kind of, the way that I thought about it actually is I didn't know that I wanted to work in research at all. I thought that I just wanted to be a clinician. And so, for my fellowship, I did a fully clinical fellowship. So I was 100% clinical. But I always kind of had that itch. And I kind of was like, well, I kind of do want to see what it's like to do research. And I was also at the time thinking of starting a family. And I was like, clinical work demands that you're in the clinic 9 to 5 at least, right? If not more. And so I was always curious about what it would be like to, have a more flexible role where I can work from home more, for example. And so I knew after fellowship that if I didn't do research at that point, that it was never going to happen, or it was going to be very difficult for it to happen later. And so I transitioned from 100% clinical to 100% research. And now I've been there, at Sinai for almost 9 years now, and I've been able to have a little bit of a balance, right? Where I do mostly research and have some clinical time as well. And honestly, like if I wanted 50-50, I can easily do that at this point, right? So like now having both has been great. But I would say that a lot of neuropsychologists tend to stick to one thing. So it's not super common for someone to have wear as many hats as I have, but it's totally doable if that's something you're interested in.
Okay, wow. Thank you for answering my
Yeah,
question.
of
Oh,
course.
would you
Yeah,
say that kind of have that flexibility that you wanted? Okay.
totally. Yeah, I work from home usually 3 to 4 days a week. And I go into the office to see patients 1 or 2 days a week. And it's based on my schedule. Like I schedule my own patients. So if there's a day that I can't go in, I can schedule them for a different day. And so that's been a really awesome part of my job. I definitely have, meetings and it's something where you have to be you have to have a lot of initiative and be very self-motivated because no one is breathing down your neck telling you to submit these grants. But when you work in research, we call it a soft money position, meaning that you are submitting these grants to support your own salary. So if you don't get the grants, you have no salary, right? So like it's different than clinical work where the hospital employs you, they pay you a salary, whether or not patients come, this is your salary, right? So you're also depending on the funding environment, you're depending on getting the funding. So you have to have a good team in place and have good resources to help you, put these grants through and everything. So um, it's not for everybody, but it's something that I enjoy, and I enjoy that like persuasive writing, and I like, I know that I will get the work done essentially. So,
Thank you.
um, yeah, and so, oh, Priscilla,
Hi, sorry, I had a quick question.
sure.
So, what would be the difference between a PhD neuropsychologist and a neurologist? Because both of them are within the focus of the brain. So, I
Yes.
just want to know.
Yeah, so a neurologist is an MD. So a neurologist goes to medical school and they have a different view and a different way to diagnose conditions. And so a neurologist is more concerned with brain structure and integrity and less concerned with functioning. So a neurologist is essentially a doctor of the brain. A neuropsychologist is more a doctor of brain behavior relationships. So we're more concerned about the behavior portion, right? So like what that looks like day to day. So we work very closely with neurologists. So an example would be a patient might go to a neurologist because they're having cognitive problems and they think it might be dementia. The neurologist might do an MRI and say, I see some volume loss in your brain that is not really age appropriate. Let me send you to a neuropsychologist so we can see what the pattern of your deficits looks like so we can determine what diagnosis it might be. And then they would send them to us. we would do a cognitive evaluation and look at different aspects of their cognition, as I mentioned, and look for patterns, and say that the pattern of deficits is language and memory. Well, that's squarely in the Alzheimer's area, right? And so then we might write a report and go back to the neurologist and say, we saw your patient and it looks like this is the diagnosis that we think it is. Does that make sense? Like it gives a life to what they're seeing on a scan, and it's all integrated in order to care for this patient. So we work together very closely, but we do very different things. Does that make sense?
Yes, thank you.
Okay. So for those of you who are interested, how you become a neuropsychologist. So obviously a bachelor's degree is the first step. Having a psychology degree is helpful, but it's not exactly the requisite. Like I have a lot of colleagues who did biology, who did neuroscience is another big one, right? So a lot of different majors here are well accepted by doctoral programs. But as I said here, the research experience matters much more than what the major is. So as long as you're doing a bachelor's degree and you have the ability to get some research experience during your bachelor's degree, that's really helpful. And if you didn't have that during your undergrad, then doing it after, like either through a postdoc program or volunteering or working in someone's lab for a few years is really helpful, or getting a master's degree where you can specifically work in somebody's lab also, that's helpful. And then, interestingly, you don't have to get a PhD to be a neuropsychologist. You can also get a PsyD. A PsyD is a doctor of psychology, whereas a PhD is a doctor of philosophy. The main difference, other than the name, is simply that the PsyD is a more clinical degree, so it involves a lot less research. So people with PsyDs usually don't go the research route because they get very little research experience during the course of their programs. So it's a lot easier to get into a PsyD program than a PhD program. That said, the PhD route is the one that's funded. PsyD is usually not funded, so you would have to pay tuition for a PsyD. And then again, as I mentioned, the pre-doctoral internship, so you have to match somewhere. And it's very competitive. So literally, I remember my first semester in when I was in the doctoral program, I started looking into internship programs. So it was like I knew I had 5 years to go, but you already have to sort of start looking and mapping out where you might want to go. And then the postdoctoral fellowship, and then the license. And then another thing that you can do as a neuropsychologist is you can get board certified. So, just like a lot of physicians have board certifications, neuropsychologists can be board certified or not. Board certified is the gold standard for clinical neuropsychologists. So, if you want to do clinical work, if you want to work in research, there's sort of no reason to be board certified. So, it's not a requisite. Um, I would say, if you're just starting out now, get into a lab early. So again, I know grunt work isn't fun, but it is how science actually moves. And I can tell you, as a scientist now, how critical it is to have students in my lab. It's something that we really appreciate, and I try to help them as much as possible and give them co-authorship on manuscripts and things like that, and write recommendation letters and etc. So that's always really helpful. Grades really matter, but it's more important that you have like a trajectory that makes sense and a story that makes sense. So, it's okay to sort of start broad, but have a sense of where you're going roughly, right? So, for example, if you want to be a pediatric neuropsychologist, you should have some child experience, right? And sort of work your way toward that goal. Even if you start out working, with autism or with, pediatric cancers or different kinds of things like that, it's doesn't matter as much as long as you're sort of telling a cohesive story. Um, Rejection is real in this, as I mentioned, 2,000 people applying to our program this year and only seven got in. The path is long. There are a lot of setbacks. A lot of people that I know didn't match for internship year and had to try again the next year. A lot of people I know didn't get their dissertation defended in time, and so that meant that they had to do 2 more years or 1 more year of their PhD. And so these things are actually very common. It's less common that someone just finishes in 5 years and that's that. So, um, I would say like resilience is a really big part of this. Um, Shadowing people and working in labs of neuropsychologists before you commit to doing this. And I would say for anyone thinking of any kind of healthcare job, this is really critical because a lot of times we, sort of make it seem like it's a very glamorous job and it looks completely different from the inside. So being able to shadow before committing to graduate school is really, really important. Finding some mentors, who can write you an honest letter, and sort of tell you the truth about the field and sort of how to get to where you need to go, is really important. And also self-care, and as a neuropsychologist, I preach this all the time, and I probably don't practice it as much as I should. But I would say, self-care is really important, and just giving yourself grace while you go through that period. So I'm happy to open it up to the 30 questions in the chat. Um,
I think we got way more than 30 at this point. We are
yeah.
really excited about. Thank you so much, Dr. Becker, for
Of
sharing.
course.
We do have a lot of questions, like I said, so I'm going to try to combine some of them that are kind of the same subject matter. Additionally, if you asked multiple questions, we might only get through one in the session, but feel free to email us afterwards, and then we can coordinate with Dr. Becker to get any specific questions answered. So starting off in the chat, I see, are there any current genetic therapy regarding improving cognitive function and preventing regression?
Are we talking about cognitive decline or are we talking about, I'm going to assume to prevent progression? No, right now there are no genetic therapies, and unfortunately, there are no known treatments for cognitive impairment or cognitive decline. There are some in the Alzheimer's literature. We know that there are some drugs that have prevented progression to some extent, but they don't reverse the decline. Um, and it's very dependent on the patient. It's very dependent on the phase at which we capture them too.
The next question I see is, which category of intelligence or cognition would social aptitude or awareness fit into, or does it vary?
Which category of intelligence or cognition would social aptitude? Yeah, so um, this would be called social cognition. I don't know if this is, the appropriate way to answer this question, but um, it's not really in part of intelligence per se. Social cognition are things like theory of mind and being socially adept. And these are things that we see, for example, in autism tends to be impaired and in many other conditions as well. I would say like it certainly varies, but social cognition is the general category that it would fit in. Um, but, I would say social ability itself doesn't really have a stable sort of home because the frameworks that carve up like intelligence were built on different foundations, so anyway, um, it's sort of a classic psychometric issue, but hopefully that answers the question.
I think it did. Next one I see is, how far back is a head injury? Do you look to see if the symptoms are caused by it? So how far back does the head injury occur for you to see if the symptoms that are currently presenting are from the head injury? If I didn't articulate that right, feel free to correct me, whoever
No,
asked.
no, I think the question is worded a little bit weirdly. I'm guessing what they mean is if a remote history of a head injury can cause symptoms later and whether you can see that. Is that
I think so.
yeah. So I would say it depends on the severity of the head injury. You can have a concussion or post-concussive blows and have no symptoms at all. And then, later in older age, when it interacts with other factors like genetics and lifestyle factors, can create this situation where you get specific protein depositions called TDP-43 and phosphorylated tau that sort of aggregate in particular areas of the brain. And that is what translates to what we know as chronic traumatic encephalopathy. Um, but it really depends on the severity of the head injury. Like I would say, if I saw someone today who told me that they had a very severe head injury 10 years ago and they lost consciousness and were hospitalized and were in a coma and they still have cognitive deficits, that wouldn't surprise me at all. And I would certainly attribute it to it. But if it was a more mild one and they're still having trouble, I would have a harder time attributing symptoms to that. And then in that same question, I don't know if we want to tackle those, but does diagnostic include mental related diagnosis like ADHD, autism, et cetera? Um, yes, I think if you're referring to when I say we diagnose people, yes, so absolutely we can diagnose ADHD, autism, mental health related conditions. But diagnostic also includes things like Alzheimer's. We can say, stroke. We can say long COVID. There are many, many diagnoses. We can say, sedative induced neurocognitive disorder. We can say mild neurocognitive disorder, major neurocognitive disorder. Those are among the many, many different diagnoses. Basically, anything that is an ICD-10 code, we can diagnose. And when creating a plan, who do you consult with, and does your team follow up with patients' treatment to determine progression? Yeah, so when we create a plan, I don't typically consult with anyone except think through the patient's individual case. If it's a unique case, I might seek expertise from, someone in that area. But generally speaking, most of the patients that I see are sort of need the same level of treatment. And so the treatment plan doesn't differ so substantially. But yeah, we then after creating a treatment plan, we invite the patient back for feedback and sort of talk through, what we recommend with them. We talk to the referring provider and explain what our treatment plan would be and sort of help guide treatment in that way. Hopefully that answered that complex question.
I also see we have a few questions in the chat about your work-life balance and your experience with burnout, if you could share.
Yeah, I would say work-life balance is really interesting because I used to think that work-life balance meant that you have to have everything perfectly balanced, right? Like allow perfect amount of time for your, personal life and a perfect amount of time for your work life. And I just don't think that it really works that way. I would say like what's more important to me now is being present wherever I am, right? So, I have three kids, three young kids. And so when I'm with them, I'm not on my phone. I'm not on my computer. I try my best to just be present and focus on them. And when I'm at work, I try to not be, buying clothes and shoes for my kids and be focused at work, right? And so it's not an easy thing to do, but I think being present wherever I am has become more important than being perfectly balanced. I think sometimes my work requires more of me and sometimes my family life requires more of me. And so I try to triage when I can. Um, but I would say that I'm happy with the balance that I have. I think that I'm doing work that is really meaningful. And I'm really proud of that and think that my kids will one day see that and appreciate that as well. Um, my experience of burnout is real. I would say it happened much more substantially during internship than at any other point in my training. So I did my internship at Mass General Hospital through Harvard Medical School. So I lived in grad school housing. And so I had to move my entire life for just 1 year. And to be honest, I lived in Boston for 1 year. And when people say, well, what do you think about Boston? I don't know anything about Boston because I really just worked that 1 year. Like I don't feel like I had any time to really explore and do any of the, fun things in Boston. So um, I would say, burnout is the reality of the job sometimes. I think it's the reality of the training, but I think knowing your limits, knowing like learning when to say no to things is really critical, and not always easy, but it's a skill you learn over time. Um, so yeah, I would say that those things are just important to think about and knowing when you're burning out so that you can pump the brakes is important too. Um, Biggest opportunities in neuropsychology in the next oh, that's a good one. The biggest opportunities I see in neuropsychology in the next 10 to 20 years, I would say, is AI and digital cognitive evaluations. Um, you know, every time I tell a colleague, when I'm explaining neuropsych assessments and I say, we use our paper and pencil test, they're like, what does that mean? And I'm like, well, we print out the paper and then they have to use a pencil. They're like, what? Like, this isn't digital? There's no iPad, there's no, and truly it's because every time a test is created, you have to validate it for an entire huge population. And so the normative data that we have is based on large amounts of data and large populations. So you can't deviate from that standardized way of administering the test. And so for decades, we've just been very far behind and haven't, had that validation data for digital assessments. Now we're starting to, just in time for AI to take over and change it all up again. So I would say that those are some of the biggest areas that I see changing in neuropsychology.
I wanted to jump down just a little bit. I saw we have a lot of high school students here, and they wanted to know a few people what work that they can do in high school to maybe stand out if they know that a PhD is what they would want in the future. Any opportunities that they should be involved in.
Yeah, I would say, there are anything healthcare related would be fine. Um, you know, I'll be honest, in high school, I had no idea that I wanted to go the PhD route. I actually thought that I might want to be a lawyer, and I remember I interned at a law firm my senior year before college, and I was like, no, this is not what I want to do. But so. I think in high school, like, yeah, sure, if you want to get some research experience and volunteer in a lab, that's great and see if it's something that you might want. Um, but it's also okay to, just do good work in your classes and get good grades and get into a good college where you can then do those things. I think so much changes in college, even through my PhD, like I completely changed my track, right? So like we're all just trying to refine what we want to do. So whatever will get you closer to understanding what you want, I think do that, volunteer, shadow, that kind of thing.
And for folks that are in general, no matter what level they're at, does the paid work have to be directly related to their ultimate subject of interest, or is general field experience good enough to make them stand out for a PhD?
Yeah, I would say general research experience. So you have to have a basic understanding of research methodology, right? Like understanding what a cohort is, what reliability and validity is, right? Understanding the process of informed consent, like just very like research 101. It's super helpful even if you end up going into an area that is totally different. Than what you started volunteering for in your lab. I'd say obviously the more similar the better, but it certainly doesn't have to be that. And I think again, just showing that you have an interest in research and that it excites you is really key.
Additionally, how important is it to get published to apply for PhDs as an undergrad?
Yeah, so I don't think I had a single publication actually when I applied for my PhD. I definitely had poster presentations. So that's a little bit different where, I was already working in a research lab, and so there was a lot of data there. I had a mentor in this research lab who, helped me put these posters together and publish them or and present them rather at different conferences. So I never actually had a publication before, but a lot of my colleagues did, at least as co-authors. So I would say like having one would be awesome to get into your PhD. Having multiple, that would be a huge plus, but having none doesn't mean you won't get in. Um,
What would you say that you or other PIs look for a student who wants to be part of their lab?
um, I would say like personality fit for me is actually the biggest thing. Because I think that if the personality fit is right, like people, like it's a learning experience. So I'm not necessarily looking for someone who like checks specific boxes or anything like that. I know that when they're coming to me at entry level, right? Like they're here because they want to learn. So I'd say personality fit to me is the most important. But second most important, I would say, is just the person being genuine about their interests. I find that a lot of times, and like the emails that I usually will, I don't want to say ignore because I never ignore them. I always reply, at least to say, that if I have an opening or not. But the emails that I'm usually not so interested in are the ones that people like have copied and pasted like whatever they Googled about me and said like, I'm very interested in exactly this research that you're doing when it's very clear that they have no idea what it means or like, and so I'd rather somebody come to me and be genuine and say, "Hey, like I have an interest in, quantum physics." And, this has been a really interesting thing to learn about your research. And, I'm looking for a research role and your lab seems great. And I would love an opportunity to work there versus someone who says like, I'm very interested in long COVID cognitive functioning and the specific, very specifics of what I'm doing, when they have not demonstrated that at all. So being
Okay,
authentic.
that is super helpful. Thank you. I know you mentioned earlier some of the organizations that you got involved in. Can you share those? Somebody was asking for a refresher.
Sure. So, the American Psychological Association is a good place to start. They have several divisions within the APA, like Division 40 is the neuropsych one, but they have many others. And the APA is the organization that accredits all of the PhD programs. So when you go into a PhD program that's prestigious, it's usually an APA accredited program. So that's number one. And then there are many others like the National Academy of Neuropsychology, American Academy of Clinical Neuropsychology, International Neuropsychological Society. There are many different ones, but easy to Google if you're interested.
Sounds good. Thank you. Um, a little bit more about you. Why specifically did you decide to choose your path when going into neuropsychology, or was there a specific moment that you knew, like, this is what I want?
Yeah, I think it just led me there. I think that, I was really just interested in the different patients that I was seeing. I also think that I recognized specific limitations of my master's degree where, when I was finishing college and I thought that I wanted to be a therapist, I went for a master's in mental health counseling. And I was working as a therapist in clinics and private practices, and it wasn't fulfilling me. I was seeing these things come up and I was like, "Oh, I wonder why this is." But like I found that I never had the time to like really look into it further, and I was always just seeing patients, writing notes, seeing patients writing, and I was like sitting in an office, patients were coming in and out of that office all day, and I was just, sitting like literally just sitting there the entire day. And it was exhausting, and I felt more burnt out from that than anything that I do now. Um, it was like heavy work. You're, in charge of a lot of people's emotions, and I just found that it wasn't as fulfilling as I always thought that it would be. And so, but I knew that I was interested in psychology still, and I knew that like these were all things that I like. It wasn't exactly what I wanted to do, but I was close. And so to me, the logical next step was the PhD, which was going to open up the job flexibility, that I was hoping for. So, where I could do something other than just being a therapist at a clinic or a private practice, but that I could do research, I could teach, I could, do clinical work if I wanted, and so on and so forth.
Thank you. Someone else asked, what was your PhD dissertation about?
Ooh, good question. I did psychosocial and cognitive evaluations in liver transplant recipients, and seeing whether they were actually predictive of outcomes. So what that means is people who get solid organ transplants are often on immunosuppressant medications to prevent them from rejecting the organ that was transplanted. So in this case, the liver. Um, in order to go for a transplant, though, after you're on the transplant list, you have to go through a psychosocial evaluation. So the psychosocial evaluation essentially tells the transplant evaluators that the person who needs a transplant is going to benefit from that transplant, and is psychologically ready for it in that they will be able to take their immunosuppressant medications, etc. And what I found actually, and this is like standard process, you cannot get in the whole of the United States, you cannot get a transplant, even if no matter how bad you need it, unless you have passed this psychosocial evaluation. But what I found in my dissertation was that the psychosocial evaluation did not predict outcomes. In other words, the whole reason for it was that we were hoping to have better transplant outcomes, and I found that it didn't predict it at all. So I published it, and yeah, I did that kind of transplant work for a few years. Um, and yeah, worked in a bunch of different other chronic illnesses before the pandemic. So very different work though than what I do now.
I see someone asked if you decide not to get a master's degree, is there any standout lab experience or certifications that you could get that could elevate you if you only have a bachelor's?
No, but I would say going straight from a bachelor's would be near impossible. I would say you need like at least 2 years of research experience after your bachelor's. So, a lot of people will finish a bachelor's, work as like a project manager at a lab. I will say that like over the last several years, I've had maybe 9 different project managers because all of them go on to PhDs. So they start, they have bachelor's degrees and work in my research lab, and then eventually graduate to going for PhD programs. Um, so yeah, so they usually like stay for 2 or 3 years and then move on.
I see a couple of questions for folks asking about letters of recommendation, if it's important to get a letter of rec in the science or psychology related fields or from faculty members in general.
I would say the best letter of recommendation is the most personal one, the one that of whoever knows you best. So I'm not usually looking at, what the person's degree is or how senior they are or anything like that. I'm looking at like how much do they actually know this candidate? How much can I actually trust what they're saying about this candidate? And is this a generic letter, or is it telling me something? Am I learning something new about this candidate by reading the letter, right? Or is it just echoing everything else that the candidate's application already tells me? So those are the things that I look for in a recommendation letter.
Thank you. Do
Yeah.
you frequently work alongside psychometrists?
Yeah, so a lot of neuropsychologists in clinical practice do. So psychometrists basically will administer the test for a neuropsychologist because the expertise of the neuropsychologist, of course, is in the administration of the test, but it's more the test selection and interpretation that makes a neuropsychologist unique, is that we understand the sensitivity and specificity of tests, the psychometrics of tests, which test for which patient at which time. A psychometrist essentially like understands the psychometrics of the tests themselves and not of the conditions and not of the patients. And so they're very good at administering the tests, at scoring the tests, at norming the tests, and then passing them on to the neuropsychologist who can do the sort of more clinical parts of the work. So I personally don't work with a psychometrist because I don't have enough of a clinical caseload to need one. Mostly my postdocs are the ones testing patients, and it's part of their training. So, I often don't have them use a psychometrist for that. Uh, and for research, usually clinical research coordinators are the ones that will be administering the tests. And by the way, those are bachelor level people. So my research coordinators have a bachelor's degree and they administer a lot of the tests that we give in research contexts and often will go back to get a PhD also.
Do you think that there is a high demand for neuropsychologists?
Huge. I would say like at Mount Sinai, we maybe have 15-ish different neuropsych, maybe a little bit less, maybe it's more like 13 neuropsychologists, I think, in the entire health system, and not one of them has less than a 1 year wait list. So it's usually a very sought after profession. Um, I also don't know a single neuropsychologist that needed a job and couldn't find one. So um, I'll say that.
Okay, sounds good. In general, do you have any other helpful skills that are maybe more non-medically related that you think folks would benefit from? Like public speaking or I don't know, any specific jobs that you think prepare people for what they'll see?
Um, Public speaking. Uh, I don't think I know of anyone exactly. Are they asking for skills or for people that will
Or
help?
like skills that they should
Oh,
learn
sorry.
that'll help them.
Um, Public speaking is not a requisite. If you want to work in research and you want to present research findings, then being good at public speaking might help you for giving presentations and lectures and things like that. Um, I would say networking is exceptionally important. I think that the majority of the connections that I've made thus far have been because I purposefully like sought out networking connections and conferences and things like that. People that I met have introduced me to other people and sort of, building my network is how I stay busy. Um, yeah, I would say that that's the biggest one. I don't think public speaking is necessary. I would say writing skills are really important. And I will say I am very aware of AI and that takes care of a lot of the writing for a lot of people because it can make things sound better. Um, but I'm embarrassed to say how many people I've seen recently like send me drafts of papers they want to publish where I can tell in 2 seconds that it was written by AI and they're very um, it's just very obvious. So I would say like somebody who's good, genuinely good at writing and it's not AI. That's a really important skill.
Okay. I think we have time for maybe one more question. How did you get access to conferences? Maybe specifically if you are at a smaller university that isn't R1.
So conferences are usually national and international, and you have to pay to attend them. There's a registration fee, but they often have discounted rates for students. So, you just sign up. So you just can go to their website, you can register as a student to be a member. And you can pay the registration fee. It's not an ideal way to do it, but usually, like when you're a part of a lab, a lot of times the lab will cover those expenses for you to be a member. But even still, it's a 1 year membership and you have to renew it every year. So, but a lot of these conferences will do student rates that are like $35 to register for a conference. Whereas like for professional membership, you have to pay like $1,500 to attend the same conferences. So, you know, I think that it's a great place to learn though. And certainly somewhere that I've really appreciated being a part of because it's people who are really passionate about the field, and you just attend these talks and just learn so much, and it's really awesome to see.
Thank you so much. One more real quick that I did see pop up a couple times is if you see any challenges for international students within your field.
Yeah, I think, one of the things that I see coming up a lot is because of research funding, through the NIH, especially being a challenge sometimes for international students, or, like we have a T32 postdoctoral fellowship program, and because it's NIH funded, it has to be for students who have, or for postdocs who are citizens, and so those are some challenges, but I would say like international students, shouldn't struggle at all to get any kind of clinical job. It's really just in the research field that I see it being a problem.
Okay. Thank you so much, Dr. Becker. We are
My
coming up on
pleasure.
So I do have to share our wrap up, but we're so appreciative for all the advice and you sharing your trajectory, your current research, specifically kind of getting into the nitty-gritty because I know folks are trying to get into the field. So you sharing your path there is super invaluable. Thank you.
Of course. Of course. Happy to help. Take care, everybody. Have a good night.
All right, folks, we're going to jump into our wrap up. Um, Here we are. Okay, so we encourage all of you students to take some time to reflect on this session. It's really important that you take the time after any session that you do to kind of think through the notes that you took, any questions that you have, any further research that you want to do, and feel free to send us an email at info@prehealthshadowing if anything else comes up. Additionally, we'd love if you could share your insights on LinkedIn. Like I said at the beginning, LinkedIn is a professional social media platform where you can expand your professional network. So feel free to tag us, also follow us over there. And I would also encourage you all to follow any of our professionals that you find on LinkedIn to stay up to date on any of their research or get in contact. I know Dr. Becker is in the research field, so if any of you are on that coast and wanted to check in, that'd be a great way to do it. Again, shameless plug, if you're interested in being a part of pre-health shadowing, we really do enjoy it and we would love to have you on our team. 100% remote opportunity, and there is more information on our website. Also, if you can donate, please do. Another great way that you could help PHS out is to send this QR code to anyone in your network that you know is interested in helping the health professions. That would be very, very appreciated. And again, donating your time. All right, the moment you've all been waiting for, earning your digital certificate. Your digital certificate will be available as soon as you take the post-assessment quiz and pass it with a 70% or higher. You do get two opportunities to take this quiz for your virtual shadowing hours, and it is open indefinitely for your experience, for your convenience, as well as anyone who's watching this session after the fact when it's posting it on YouTube. The certificate is live. If you missed a part of today's session or want to check out any of our other sessions, please visit our YouTube channel at Pre-Health Shadowing to watch any of them or just to re-go over a session, hear anything for a second time. We're super proud that we're able to get those up for everybody to make it more accessible. And be sure to catch our sessions every single week. Please stay up to date with our email as well as our website to see future sessions. Our next session is July 3rd, so we hope to see you all there. Thank you so much again for joining. We're super appreciative of Dr. Becker and her time and advice. Feel free to stick around if you have any questions and ask our student team. And thank you again so much for joining. We really loved having you all here. And thanks for all your great questions.